everyone, welcome to this video where we will be discussing skin and systems, that is dermatological manifestations of a few important systemic diseases. To begin with, we have nutritional deficiencies, which is very important both for your clinics as well as for your exams. The first that we have here is Pellagra, which happens due to deficiency of vitamin B3, also called as niacin. Common risk factors for this include people who have a predominant maize eating or corn eaters, then chronic alcoholics, as well as treatment with isoniazid, that is, the patient is on ATT. Now, the typical triad of Pellagra can be remembered as DDD, that is, diarrhea, which is the first symptom of Pellagra. So remember, it begins with diarrhea. Then there is dermatitis and dementia. If left untreated, a fourth D is added, that is death. So diarrhea, dermatitis, dementia, and death. In the skin, the rash in Pellagra is a hyperpigmented photosensitive rash, that is, it is present in areas which are exposed to sun. That includes face, neck, and the hands. Now, on the neck, when you see this hyperpigmented rash in the V distribution, it is called as the Casal's necklace. A very, very important image for all the exams. Casal's necklace will be this V-shaped rash that you see in the neck. Now, similar rash when present on the hands is called as the Gauntlet sign. Gauntlets were metal gloves which were worn in the older times. You might have seen that on the hands of some villains in old Hindi movies. So that is why it is called as the Gauntlet sign. Next, we have vitamin B2, that is riboflavin deficiency. The first and the most common thing that you see is this rash on the corners of the mouth. This is called as angular cheilitis. So remember, riboflavin deficiency is one of the causes of angular cheilitis. Then there could be inflammation of the tongue, that is glossitis. And lastly, patients may be at increased risk of developing seborrheic dermatitis, especially in the nasolabial folds. In the eyes, what we see is neovascularization of the cornea. So the eyes, we see neovascularization of the cornea. Then we come to vitamin B12 deficiency. In the skin, this presents as a bilateral, symmetrical hyperpigmentation of the skin. Commonly seen on the face, especially around the eyes, then on the palms and soles, as well as increased pigmentation of the creases. As you can see in the image here, especially around the nail folds, then on the interphalangeal and the metacarpophalangeal joints, then the palmar creases. These are all deficiencies of vitamin B12. Now, while it increases pigmentation in the skin, it reduces that in the hair. That is premature graying of hair, which is also called as canitis. So vitamin B12 deficiency is a cause of premature canitis. In the mucosa, you see this patches of glossitis. So this causes glossitis in the tongue. Now coming to vitamin C deficiency, which is called as scurvy. The manifestations on the skin and the mucosa include bleeding gums, which is a very important part of all questions on scurvy. Then you see these small hemorrhages on the skin, especially around the hair. It is called as perifollicular hemorrhages, as well as petechiae are seen. Then these small raised bumps around the hair, as well as twisted hair, these are called as corkscrew hair. So these are important manifestations of scurvy. Now coming to Phrynoderma, which is very important, has been asked twice in the last 5 years of the NEET PG exam, happens due to deficiency of vitamins A, B, E, K, as well as certain fatty acids. Now, common age group where you see this is a child who may be having features of malnutrition as well as there may be specific deficiency as well in the child, especially when it comes to vitamin A. So there could be a history of night blindness or difficulty of seeing things at night. Now, the area where the rash is seen are the elbows and the knees. So the site that may be mentioned in the exam are the elbows and the knees, or you may be given an image about that. When you see the image, what do you see? You see these raised papules around the hair, which are called as perifollicular keratotic. They are slightly hard and rough. So perifollicular keratotic papules, which are present on a dry, rough skin. So the background here is a dry, xerotic skin, and then you see these small bumps on it. Because of the bumpy appearance of the rash, it looks like a toad. So Phrynoderma is also called as toad skin. Now, next we have is Acrodermatitis enteropathica, which is due to deficiency of zinc. This is a disorder which is inherited in an autosomal recessive pattern. The gene that is responsible is the zinc transporter gene, SLC39A. Because of this defect, there is a defective zinc absorption from the intestine. Now, as long as the child is breastfeeding, the zinc in the breast milk is highly bioavailable. It is still absorbed. But as you start weaning, the zinc in the outside food sources is not absorbed. The child starts showing features of acrodermatitis enteropathica. So the onset is generally after 6 months of age, during weaning. The typical triad here can be remembered as DAD, that is diarrhea, which is also the first symptom here. Then alopecia, as well as dermatitis. So the typical triad here is DAD. Differentiate this from the DDD, which was seen in Pellagra. Along with this, there may also be history of poor wound healing in the patient. Now, when you see the skin, the name here is acrodermatitis. Acro means the acral areas are commonly involved. So you see the rash on the face, especially around the nose and the mouth. That is the periorificial rash. Then on the hands and the feet, as well as the groin. So the sites for this rash are the acral areas, especially the periorificial and the perineal sites. Now, initially in the acute form of the disease, this is an erosive rash. So you see this erosive rash in the images of the groin, on the neck. Here in this child, that is what is commonly seen in the images in your exams as well. As it becomes chronic, this becomes a scaly rash. Along with this, there may be hair loss, that is alopecia in the patient. Now, coming to iron deficiency anemia, the manifestations that you see here are these spoon-shaped nails, which is also called as koilonychia. So remember, koilonychia is seen in iron deficiency anemia. Coming to protein energy malnutrition, where we have kwashiorkor and marasmus. In kwashiorkor, the two important features on the skin that we see are the flag sign, which is seen in the hair, that is alternating areas of light and dark hair. So what you see are alternating bands of light and dark hair. This is called as the flag sign. Then on the skin, there is this scaly skin which is flaking off. It is called as flaky paint dermatosis. So what are the things that you see in the image? Dry, flaky skin. Marasmus, the typical facies that we see are the monkey facies. Now, coming to skin and endocrine systems, there are certain endocrinological diseases which also show important cutaneous features. We'll be reading about thyroid and diabetes. Now, when we talk about the thyroid gland, we could either have manifestations of hypothyroidism or hyperthyroidism. So let us see what happens in both of them. In hypothyroidism, the skin becomes dry, xerotic, and itchy, while in hyperthyroidism it is a smooth, moist skin because of increased sweating. The specific skin features that we see here is myxedema in hypothyroidism, while in hyper we have pretibial myxedema. So remember the difference between myxedema and pretibial myxedema. That is seen in hyper. Along with that, there may also be thyroid acropathy. Now, the hair in hypothyroid patients become dry, rough and brittle, while in hyperthyroidism these are fine hair. Specific conditions in hypo may be associated with chronic telogen effluvium. The nails again become rough and brittle in hypothyroid patients, while in hyperthyroid patients these are smooth nails. Now there may also be another specific feature that is associated here. These are called as plumber's nails. That is onycholysis of the nails seen in hyperthyroid patients. So there is a separation of nail plate from the nail bed. When this happens in hyperthyroid patients, it is called as plumber's nails. So now what's happening in pretibial myxedema? Remember, this is only seen in Graves' disease. It is not seen in all causes of hyperthyroidism, only in Graves' disease, because here there is an increased deposition of glycosaminoglycans in the skin, because of which the skin becomes raised and indurated. So what you see here is raised, indurated skin, and it is shiny. So because there's something which is depositing in the skin, it becomes raised, it becomes firm, and it is commonly seen on the shins. So even though the term myxedema is used with hypo, remember this is seen in Graves' disease. Now coming to certain cutaneous manifestations of diabetes, we have diabetic dermopathy, granuloma annulare, necrobiosis lipoidica diabeticorum, as well as increased risk of all viral, bacterial, fungal infections in the skin in the diabetic patients, especially with uncontrolled sugars. Now, coming to diabetic dermopathy, very common, you may have seen that in elders in your family. What you get are these hyperpigmented atrophic macules on the shins. So these are hyperpigmented atrophic macules on the shins of the patients. This is an indicator of a long-term disease. So this patient has had disease since a long term, and it may be associated with changes in the retina, skin, neural, as well as renal changes in the diabetic patients. Now, in granuloma annulare, the name of the disease itself is telling us what is happening here. Granuloma means we see granulomas in the biopsy. Annulare means we see annular lesions on the skin. So remember, these are annular plaques. What are annular plaques? That are ring-shaped. So look at the lesion here. You see the margin here? So that is the annular lesion here. Whenever we have annular lesions, we have to see what are the findings in the margin as well as the center. The margin here is skin-colored beaded margin. What is the meaning of beaded? When you look closely at the margin here, you see small beaded look in the margin here. So that is why it is called as beaded margin. And the center is normal skin. A very important point about granuloma annulare is that it is asymptomatic. That is not itchy. So that is something that's important because it helps us differentiate it from other annular lesions. It helps us differentiate from fungal infections which are itchy, which are also more common in diabetics. So when you see this asymptomatic skin-colored annular plaque on the skin, you have to know that this is granuloma annulare. Common sites for this are the dorsum of hand as well as the shins. And in the biopsy, we see palisading granulomas, as well as collagen degeneration. Now, even though I have told you that Granuloma annulare is associated with diabetes, but there are some other important associations that you have to remember. Apart from diabetes, it can be associated with insect bites as well as certain vaccinations. But remember, there is no association with malignancies. So Granuloma annulare is not associated with malignancies. The next we have is Necrobiosis lipoidica diabeticorum. Here, what you see are these yellowish waxy lesions on the shins. So these are yellowish waxy plaques on the shins. When you look at their surface, do you see that these are slightly atrophic? They are depressed. So yes, these may be depressed and atrophic. Then the dilated blood vessels are visible on the surface. So we see telangiectasias, and there may be small areas of ulceration as well. You have to mainly differentiate this from pretibial myxedema. In pretibial myxedema, it was raised and it was shiny. Here it is yellowish, it is depressed, it has telangiectasias and ulcerations. Plus the clinical setting is completely different. That was seen in Graves' disease. This is seen in diabetics. The sites are the shins. Then metabolic syndrome can also have certain cutaneous associations. Acanthosis nigricans is more common. Skin tags are seen. It may be associated with psoriasis as well as acne rosacea and hidradenitis suppurativa. So now coming to Acanthosis nigricans, very, very important topic, has been asked multiple times across different exams in the last 5 years. Common associations with Acanthosis nigricans include systemic diseases like diabetes mellitus, obesity, and metabolic syndrome, I just told you, is associated. What is the common factor in all three of them? That is insulin resistance. Now, some drugs like OCPs, nicotinic acid can also trigger Acanthosis nigricans. Malignancies is a very important association, especially gastric adenocarcinoma. And Acanthosis nigricans is a paraneoplastic sign for gastric adenocarcinoma. Then a syndrome that is associated here is the hair and syndrome. This is a NEET PG 2021 question where HA stands for hyperandrogenism. IR is insulin resistance, and AN is Acanthosis nigricans. So an important syndrome that's associated with Acanthosis nigricans is hair and syndrome. Now, what was the common factor in the systemic diseases? I told you that is insulin resistance. What does insulin resistance do? It increases the levels of circulating insulin, which will increase the levels of insulin like growth factor 1, and when it acts on the skin, it causes keratinocyte hyperproliferation. And it is this hyperproliferation which leads to Acanthosis nigricans. And that is what is seen in the biopsy also. So what do you see in the biopsy is hyperkeratosis. So what you see in the biopsy is hyperkeratosis. That is increased thickness of stratum corneum. Remember, even though the name says acanthosis, there is no acanthosis here. And there is no nigricans. That is, there is no increase in pigment. So this name is a misnomer. In the histopath, we don't see acanthosis, we don't see nigricans or increased pigmentation. The only important finding that you have to remember is hyperkeratosis, that is increased thickness of stratum corneum. How does it look clinically? Very, very, common thing that you may have seen around you. You see this classic velvety hyperpigmentation of the skin. So the classic description here is velvety hyperpigmentation of the skin, commonly seen in the intertriginous areas, that are the skin folds. Commonly the neck, axilla and the groin can be involved. So see, this is the velvety hyperpigmentation which we see in the axilla here. The next we have is Xanthelasma palpebrum. Xanthelasma palpebrum happens because of deposition of cholesterol in the macrophages of the skin. So this is cholesterol deposition in the skin, commonly associated with lipid abnormalities. So this could be a patient with increased levels of cholesterol and reduced HDL. Then it could also be associated with certain inherited lipid disorders like hypercholesterolemia. What do you see clinically? You see these yellowish plaques on the eyelids. So these are yellowish, soft plaques on the eyelids, can be both upper and lower eyelid. These are Xanthelasma palpebrarum. So next we come to sarcoidosis, which is a multi-systemic granulomatous disorder of unknown etiology. The most common organ involved in sarcoidosis are the lungs, while the second most common is skin. Now, mostly sarcoidosis is an insidious disease, but there can be an acute form also, which is called as Lofgren syndrome. The typical triad of Lofgren syndrome is bilateral, hilar lymphadenopathy, as you can see in the image here. Secondly, it may be associated with erythema nodosum on the skin, which are painful red nodules on the shins. And thirdly, it may be associated with fever. Remember, the EN here is the EN here. So Lofgren syndrome is associated with erythema nodosum. Along with this, patient may also have polyarthritis. Another form on the skin that you have to read is lupus pernio, which is seen on the face around the nose. What you see here are violaceous, indurated plaques. So these are purplish indurated plaques on the nose with telangiectasias on the surface. This heals with scarring. The term lupus means scarring, and this heals with scarring. It may be associated with pulmonary sarcoidosis. With this, we finish our module on skin and systems.